Welcome, everyone, to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the University of New Mexico's Division of Forensic Behavioral Sciences in our Department of Psychiatry and Behavioral Sciences, along with support of the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, you can enter those in the Q&A box. You can enter those anytime you feel comfortable, but do know that we hold questions until the end, and oftentimes it's not possible for us to get through all of them. In terms of continuing education credits, if you are pursuing continuing medical education credits, there is a sign-in sheet in the chat box now for you to complete for processing those credits. If you are pursuing APA continuing education credits, you will also keep your eye on the chat box, but near the end of the presentation. At that point, there will be a link for a CEU survey that you can complete. And after completing that survey, you can get a PDF copy of CEU credits. Make sure that you copy, bookmark, open that link before the webinar closes so that you have access to it. And then make sure that you save your own PDF version of those slides of the CEU certificate. We don't have access to those after the fact. If you missed our most recent talk in the series, Dr. Jorge Varela's overview of sexual risk assessment is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube channel sometime later this week, and a version of the PowerPoint slides for those that have registered for the series will be available later this week as well. As a heads up, next week we have Dr. Heath Hodges, who will be discussing issues related to ethics, artificial intelligence, and the law, particularly in the context of forensic practice. But circling back to this week, I'm excited to introduce you to today's speaker, who'll be discussing active ingredients that drive the sequential intercept model. Today we have with us Dr. Jaymes Fairfax-Columbo. Dr. Jaymes Fairfax-Columbo is a clinical forensic psychologist in private practice. He conducts forensic behavioral health evaluations with adults and adolescents regarding a host of referral questions such as competency to proceed, mental state at the time of the offense, mitigation, Miranda Rights waivers, reverse amenability, psychosexual risk assessment, recidivism risk assessment, and post-conviction relief. Prior to entering full-time practice, Jaymes was the Associate Director of Policy and Planning for the Behavioral Health and Justice Division of the Philadelphia Department of Behavioral Health and Intellectual Disability Services, where he supported planning, implementation, and quality assurance of City of Philadelphia initiatives for individuals with behavioral health needs in the criminal legal system. He also previously served as an assistant professor at the University of New Mexico Health Sciences Center in the Department of Psychiatry and Behavioral Sciences, where he was the training director of the Postdoctoral Fellowship in Forensic Psychology. He was personally helpful in my transition here, and if you go to some of these old school law and mental health series talks when we first began, you'll see his face moderating many of these and organizing these as well. In addition, beyond his role as an assistant professor in the UNM back in the day, he is now a visiting scholar and adjunct professor in the Department of Psychological and Brain Sciences in the College of Art and Sciences at Drexel University, as well as an adjunct professor at FIU, Florida Institute of Technology. He's published numerous peer-reviewed articles, book chapters, books, magazine articles, newsletter articles, policy papers on behavioral health topics, and has done multiple of these presentations in the Law and Mental Health series related to the sequential intercept model. And so we are thrilled, Jaymes, on behalf of your old home, your forever home of University of New Mexico. Thank you again for joining our series and sharing more of this active ingredient stance of the sequential intercept model. And I will go ahead and toss it over to you.
Thank you very much. You can hear me, right?
Perfectly.
Okay, but the green box wasn't lighting up yet, so I wasn't sure. So let me give two quick shout outs. One that is maybe humorous and another one that's more serious. It figures that Heath Hodges would come on next week to show me up. I've known Heath for quite a long time. He's one of my sort of peer role models, so I highly encourage you to come to his talk. The things that he's doing with AI, I think, are just way beyond, at least where I think about it. I just think through, can I use it as like a more efficient version of Google, which I think is probably underutilizing it. But he's going to be able to talk about some of the limitations and things as well. So I highly encourage you to go to that talk. Anthony, I also wanted to give you a shout out. I didn't get a chance to tell you this at APLS, but when I went to your the talk about practicing in rural areas, one of the biggest things that jumped out to me was this concept of, they call it systemic responsivity. I've often talked before about like what infrastructure is needed to make the sim successful. And I think the term for that is systemic responsivity. Like if we're going to try to say somebody needs these resources, does the system actually have them? So maybe that is a talk for next year where I talk about systemic responsivity in the sim. So maybe I'll call my shot and say, please invite me back sometime next year so I can talk about that. But you inspired me. I took a lot of notes during your talk. So that was really great. And it's been awesome to see what you've built at UNM. Let's talk a little bit about the sim though. Last year, I gave a talk about where we can intervene along the sim, right? So we always think about the sim as here's these 6 intervention points, but we never really ask the question of, well, how do we know which place we should intervene at? We usually think about it as, well, if we miss them here, we can catch them here. So what I proposed last year was really taking a prevention science approach and thinking about different types of crime and trying to figure out which types of crime are best for which types of intercepts, essentially to prevent people from getting the collateral consequences that come along with criminal justice involvement. Today, I want to do something a little bit different. So I am going to review the sim, but I want to talk about essentially how to talk about the sim with different audiences. So it really is a blended public health and public safety model. And hopefully what you come away with today is there's 3 key public health concepts that you can use to pitch the sim to a public healthy type person. But there's also 3 key legal concepts that you can use to pitch the sim to a more legally oriented person. And so hopefully it'll help you figure out how to speak a similar language, but maybe adapt your dialect for different audiences. So moving through the administrative stuff, my bio, information on how you can get CE credits. I don't have any financial arrangement to disclose. These views are just my views. They don't reflect the views of the University of New Mexico. I also don't know that they reflect views in published literature because I don't think anyone's talked about, why they think the sim works as well as it does. And this is sort of my attempt to give 6 reasons why I think it works really, really well. A few learning objectives for today. So like I said, I'm going to overview the sim. So just a quick crash course for anybody who's unfamiliar with the sims to get you kind of up to speed so that you understand why I think these 6 active ingredients are so important and how they're reflected across those 6 intercepts. We're going to critique the effectiveness of the sim and critique, I looked up the definition. It doesn't necessarily mean I'm like being a harsh critic of it, right? It's sort of going through the effectiveness of the sim. Does it promote interdisciplinary collaboration? Does it have positive impacts for individuals with behavioral health challenges who are justice involved? And then we're going to assess the key active ingredients that I think promote culture change and that help make the sim effective. And 3 of them, again, are legal. So we're thinking therapeutic jurisprudence, procedural justice, and restorative justice. But 3 of them are public health. So we're thinking about the prevention continuum, the risk-need responsivity framework that we use for risk estimation and risk mitigation. And then we have to always think about addressing social determinants of health and mental health. Now, when I say behavioral health conditions in this presentation, I'm referring to anything that's in the DSM. Your standard psychiatric disorders, schizophrenia, depression, bipolar, neurodevelopmental disorders, so intellectual developmental disability, autism spectrum, neurocognitive disorders, people with TBIs are overrepresented in the criminal justice system. Increasingly, we're seeing people with dementia get involved in the criminal justice system. For whatever reason, I've had a number of dementia cases come my way with regard to competence to proceed and how we should think about that. And are there sort of diversion pathways that would better suit those individuals? And then substance use disorders. And I think most people on the webinar understand the robust link between substance use and criminality, although possibly best explained by the fact that we criminalize substance use in the United States. Before we get too far into things, I want to do a basic legal review and talk about different rationales of punishment. This is important when you think about some of things like restorative justice and procedural justice, therapeutic jurisprudence. Those all deviate from our traditional rationales of punishment. So we have retribution, and this is punishing individuals so they get their just deserts, Hammurabi's code, an eye for an eye, however you want to think about it. We have incapacitation, and what this means is that we punish so that we can remove individuals from society. People won't have a chance to recidivate in society if they're not in society. So we think about incapacitation. But incapacitation plays in other places. So think about the insanity defense. When somebody is found to be insane, they typically don't just go home, right? They don't go back to the community, they go to a hospital. So they're incapacitated while they also focus on rehabilitation. But when you think about incapacitation as a principle of punishment, you can also think about it in terms of probation. It's just reducing It's increasing structure, increasing monitoring to reduce the chances of recidivism. We have deterrence, and this is the idea that we punish to deter antisocial behavior. Now, this could be specific. Hey, Jaymes committed this crime. If we punish him for it, he won't do it again. Or it could be general. Jaymes committed this crime. If we punish him for it, it sends a message to everybody else not to do this. And last, we have rehabilitation. And I put rehabilitation last for a reason, because we tend to focus on those other three principles of punishment predominantly in the United States. And rehabilitation typically plays a secondary role. That is not to say that there's not a lot of rehabilitation that goes on in the criminal justice system, because there certainly is. But what I'm suggesting is that at least when mental illness is not involved, it's not something we're typically thinking about. So with rehabilitation, you're really seeking to punish to help reform somebody, to help stabilize them, and to help reintegrate them into society. And theoretically, if rehabilitation was our primary focus of punishment, it would be indefinite, right? Or indeterminate. It would be as long as we need to help somebody fill in the gaps that they have so that they don't recidivate. Now, in the United States, I'm probably not talking out of school here when I say that we've taken one of two approaches. When we think about criminal behavior, there's a punish approach, right? Things I was just talking about. We incapacitate people, they get their just desserts. We're trying to send a message to society. But sometimes we also treat people. So thinking through, what does that person need? You think about this most often in terms of substance abuse, right? Do we treat substance abuse as a public health problem and we really focus on harm reduction and trying to connect people to treatment, but we don't have any punitive outlook towards it? Or do we punish people and say, hey, there's something morally wrong with you if you're using substances, and we're going to remove you from society and toss you in jail or put you on probation? So the too long didn't read on all of the literature with comparing these two things. Neither one of them works well in isolation, right? You really do need to do them together in order to get good outcomes. So that begs this question. What if we didn't have to choose? What if we truly had a blended approach? Something that was like a public health approach that wore a public safety costume, or maybe a public health approach that happens to occur in a public safety context. Enter the sequential intercept model. So when we think about the sin, if you ask people, hey, what's the purpose of the criminal justice system? Academics are going to tell you things like this. We're going to define conduct that's prohibited. We're going to determine conditions of liability. So how are you blameworthy? And then we're going to determine culpability. How blameworthy are you? How much should we punish you based on what you did? If you were to ask Joan Q. Citizen, though, she's going to say, look, it's to hold criminals accountable, right? Somebody commits a criminal act, somebody has criminal propensities, we put them in the criminal justice system. But neither scholars nor Joan Q. Citizen says that the purpose of the criminal justice system is to punish individuals who have unmet behavioral health needs. So we end up with some real problems in the United States in terms of how we approach the intersection between the criminal justice system and behavioral health challenges. So number one, we just have an overrepresentation of individuals with behavioral health challenges in the criminal justice system, and that's at all levels of the criminal justice system. Most have said this is a byproduct of deinstitutionalization without us creating and maintaining an adequate community support network. What I don't want to suggest is that I think deinstitutionalization is a bad thing. It 100% wasn't. But maybe we didn't have the resources that we needed to make sure people didn't fall through the cracks when we deinstitutionalized. People have now started to call this, like Deboskin says, trans-institutionalization. Hey, for a certain subset of people, it's not that we took them out of a hospital and put them in a community. It's that we took them out of a hospital and put them into jails, right? So that's the idea of trans-institutionalization. They move from one institution to another. There's been increasing interest in community-based alternatives to incarceration, and this happens for a few reasons. Number one, probably most practically, it's expensive to jail people, much more expensive than to keep them in the community. You might also think about treatment-oriented reasons, right? It's not that jails and prisons and penal facilities don't focus on rehabilitation and caring for people, they do. But they also have to balance needs of custody and control in a way that a treatment-oriented setting might not have to. So jails and prisons are typically not the ideal place to treat somebody or to rehabilitate somebody. But also there's humanitarian grounds. It just feels gross to punish somebody whose offending is clearly a byproduct or at least heavily influenced by a behavioral health problem. Another problem that we notice, with the exception of substance use and maybe some cluster B personality pathology, mental illness in and of itself is not a risk factor for crime and violence. You're more likely to be the recipient or a victim of crime and violence when you have a mental illness than you are to commit crime and violence. This makes a lot of sense when we think about things like behavioral health challenges in mitigating circumstances or behavioral health challenges are exculpating, like the insanity defense. We are typically thinking, hey, if somebody committed a crime and it was largely influenced by mental illness, we need to think about that differently. And the reason we think about it differently is because it doesn't fit neatly into the idea of criminal propensity. So here I have, you can see the 8 criminogenic needs. And again, the only one that looks like it has any behavioral health nexus is substance use and maybe antisocial cognitions, again, if you think about cluster B personality pathology. Now, the biggest problem is probably that there's disparate impacts on individuals who become involved with the justice system when they have a behavioral health challenge. They often have longer lengths of stay, so they're in penal facilities for longer, or maybe they're on probation for longer. They have heightened recidivism rates compared to people who don't have a behavioral health challenge. Often, trauma sort of begets trauma. So you might have some instability in the community, you get locked up in a facility. Now you have more trauma and your underlying behavioral health issues are exacerbated. Or we have that idea of kind of deviancy training, delinquency training. Maybe you're exposed to people. You didn't have a substance use problem before, but when you come out now, you do. So often you face maybe new or exacerbated behavioral health issues. Individuals with behavioral health challenges often struggle to connect to needed services, both in carceral settings and when they return to the community. And like I was just hinting at, they often struggle to fully reintegrate into the community. There's a lot of collateral consequences. There's a lot of things that people need to stay stable. Those things are enhanced when you have a behavioral health challenge, you have more needs, and that can really make it difficult to reintegrate into the community, particularly when you're constantly scrutinized and stigmatized. But overall, it just doesn't seem just or fair to have individuals with behavioral health challenges perpetually moving through the criminal justice process. Now, we've recognized this as a country with the Stepping Up initiative. And where I am right now, Philadelphia, and where Dr. Perillo is, Albuquerque, Bernalillo County, they're both stepping up counties, right? They've committed to trying to decriminalize or reduce the overrepresentation of individuals with behavioral health challenges in the justice system. So under Stepping Up, it's really this commitment to 4 key metrics. How can we reduce the number of people booked into county jails with a mental illness? How can we shorten their length of stay? How can we increase their linkage to services? And how can we reduce recidivism rates for individuals with a mental illness? So if we go back one slide, all of the things that the SIM is trying to target are the things that Stepping Up is recognizing. So often I will talk about achieving the goals of Stepping Up via the Sequential Intercept model. So let's talk a little bit about what the SIM is. So sort of the goals of the SIM. What they say is that individuals with mental illness should encounter the criminal justice system at the same frequency as individuals without mental illness. That's just a fancy way of saying let's decrease overrepresentation of people with behavioral health challenges in the justice system. They also say what we were talking about on the previous slide. Individuals with a behavioral health challenge shouldn't have poorer outcomes than people who don't. Initially, the SIM was saying there's 5 points of intervention where if somebody has a behavioral health challenge and they come into contact with the justice system, we can try to transition them over to behavioral health resources and stabilizing resources. And the whole goal of the original SIM was to prevent people from penetrating deeper into the criminal justice system and to reduce this perpetual cycle of recidivism for individuals with behavioral health challenges. And it also advocated that the best way to reduce the criminalization of mental illness is via what they called the ultimate intercept in the original SIM. And that was an accessible behavioral health system. And to this end, in 2017, they introduced Intercept Zero, that was Abreu et al. And that really focuses, it's supposed to be a manifestation of the ultimate intercept. I think in practice, what has happened is it really emphasizes the crisis continuum, which we'll talk about a little bit, but it is this idea of we need community services to be more accessible. So going through the intercepts, Intercept 1, this precedes the criminal justice system, right? You're looking at community services here. So before you even get involved in the criminal justice system, is there something that we can do to connect people to stabilization and treatment resources? The goal of Intercept Zero is really to interrupt a behavioral health crisis before it escalates to the point where public safety is at risk, and hence you might get a call for police to respond. The focus of this intercept is keeping people out of the criminal justice system altogether. So when you think about collateral consequences, It's not just convictions that have collateral consequences. This is any type of criminal record. For example, the state that I'm in, Pennsylvania, if I wanted to look up somebody's criminal history and it hasn't been expunged, I can pretty easily see it. It's publicly available. So one, it helps kind of reduce those collateral consequences by preventing somebody from having a record altogether. But the other thing that it does is it keeps individuals in the community with their support networks, right? It helps them stay stable instead of being uprooted and having to transfer through different institutions and sort of different expectations. Some hallmark strategies. Again, this is a manifestation of the ultimate intercept, trying to create an accessible community behavioral health system, and the crisis continuum. So we'll talk about that in just a second. Now, here are some good examples of intercepts of interventions that are in Intercept Zero. Meraki in Philadelphia recently opened up a mental health walk-in center. This is designed as behavioral health urgent care. So unlike a crisis receiving center where somebody goes because they're in crisis, this is designed to help people before they get to crisis. So it's this idea of, look, let's not even de-escalate a crisis. Let's prevent them from ever getting to a crisis. Let's interrupt the crisis cycle. So this has been very successful in Philadelphia. They constantly are at capacity every day with people walking in, but you walk in, it's a one-stop shop for your behavioral health needs and your community needs. Do you need housing, right? Do you need help with employment? Do you need all those types of things? Another good example is the Riverview Wellness Village. This is a massive recovery house in Philadelphia, or it's a recovery house level of care. It's a very pretty campus. It's next to the river. Meraki is on site along with some other behavioral health providers, and all of the things that you would need are on this campus. You can stay there for a prolonged period of time, and it's really designed as substance abuse treatment and transitional housing, with the intended length of stay being up to a year, right? So when we think about substance use outcomes, when you get to a year of treatment, that's when you start to have really good outcomes. That's when you start to have lower relapse rates. So this is a community-oriented treatment program that really provides for all of your needs, behavioral health and stabilization, that is accessible without ever getting into the criminal justice system. As a side note, you can come from the criminal justice system into Riverview, but you don't have to. So there's a whole host of different pathways. So if you have a substance use problem and you don't want it to escalate, this is a great option for you. So again, you're thinking about Intercept Zero community-based interventions. If you think about the crisis system, a lot of jurisdictions employ the crisis now model. So what they're saying is, look, if there's a behavioral health crisis, we need somebody to talk to, somebody you can call, like a crisis line. Nationally, you might think of 988, although for each of your jurisdictions, you probably have some localized version of that. We need somebody to respond. We tend to think of these as mobile crisis teams. Look, if you're in a crisis and you need somebody to come out and see you, we need to get somebody out to see you. So we've got crisis lines, we've got mobile crisis teams, but then a safe place for help. So what they call crisis stabilization units. These look a whole bunch of different ways, but they're walk-in centers, right? You can walk in, you can talk to somebody about what you need, you can get connected to treatment, you can stay there for 23 hours in most places. Other places might have a little bit of sort of a shorter stay residential capacity, but it's a safe place for you to go, a safe place for you to walk into when you're in crisis without facing a long wait list or long wait times to be able to see a provider. Now, I'm going to go through the actual formal criminal justice spectrum because the next 5 intercepts fall along the criminal justice continuum. So when you think about the criminal justice continuum, you have the investigative phase. So things, you enter into the system, you get charges, they're gathering evidence because they're intending to prosecute you. We have the pretrial phase where you're doing things like, all right, now you have your formal reading of charges, you have your preliminary hearings, maybe you have like you figure out if there's enough evidence to bind the charges over and really to pursue them, or if they get kicked out and the prosecutor needs to go gather more evidence in order to bring them back. We've got grand jury indictments. So that's the pretrial phase. And you're going to see that these line up nicely with the different intercepts here. We have the trial phase where they're really focused on adjudication. At this point, they're putting somebody through the formal adversarial process. Are they taking a guilty plea? Are we going to a trial? Are we doing a diversion, but not a pretrial diversion? Then you get to the sentencing phase. So somebody's been convicted. What punishment are we going to impose upon them? Are we going to send them to treatment? Are we going to send them to probation? Are we going to say, nope, you need to be in some type of penal facility? And then the post-conviction phase is, the corrections phase. Okay, now you're in whatever facility you're in, or you're about to transition out and we have to reintegrate you into the community. This also encompasses probation and parole. So moving on to Intercept 1, that's law enforcement. Here we're at the investigative phase. The goal is really to deflect individuals from arrest. So this is the idea. Deflection is really just diversion from arrest. So, hey, we're going to divert you from the formal criminal justice system. We could have arrested you, but we're not going to. We want to funnel you back to the behavioral health system. Again, the focus here is keeping individuals in the community and out of the adversarial criminal justice system. And some common strategies are dispatcher training so that you can identify, hey, there's a behavioral health nexus to this call, deployment of specialized police response, or co-responder teams. So some examples from my time in Albuquerque. When I was there, New Mexico had a law enforcement assisted diversion expansion. So jurisdictions that already had it were trying to expand it, and jurisdictions that didn't have it were trying to implement it. And what LEAD really is, it's a deflection. It's, hey, in lieu of arresting you, we want to get you connected to case management. We want to get you into substance abuse treatment. We want to get you housing. We want to help you get a job. And it's really focused on just continually deflecting people as long as their offending is not escalating. Albuquerque also has CIT ECHO. So some of you might be familiar with crisis intervention team training. ECHO is like continuing education for that. So it takes individuals who are already CIT trained and they're able to do some continuing education. But one of the things I loved was that they would talk to UNM staff. If they had the behavioral health unit over at the police department, if they had a challenging case and they were trying to figure out what do we do, they would be crowdsourcing essentially solutions. So CIT ECHO was a great partnership that really allowed for continued training, so continued education, but also consultation to help get better outcomes for individuals who were known to have behavioral health challenges to law enforcement. Moving on to Intercept 2, you're looking at initial detention and initial court hearings. So here in the criminal justice system, you're at the pretrial phase. Again, the focus is keeping individuals in the community. We haven't gotten to the formal adversarial legal process yet, but we are moving down the criminal justice continuum. The goal is diversion from prosecution. So you formally entered, right? So you're not getting diverted from the whole system, but we do want to divert you from prosecution. We want to divert you from that formal adversarial piece of things. Common strategies here: screening and referral for mental health or behavioral health issues, data sharing between the behavioral health and criminal justice systems, and then pretrial supervision and diversion. Good examples of this are community courts. They tend to focus on quality of life crimes. They're not in the courthouse. They might be in a community center or a library. Typically, the judge, instead of looking down on you, is at eye level. And you're really focusing on getting people connected to these stabilization resources because you recognize that instability is the driving factor for offending because these are mostly quality of life crimes. Another good example that people might not think about is competency or mental health diversion. So there's a whole bunch of different types of competency. Competency to stand trial is competency to go through the adversarial process, right? Because you're intending to prosecute somebody. If you're not intending to prosecute somebody, you have a lot more options. So what you'll see is a lot of places that do this mental health diversion or pretrial diversion. They're essentially saying, look, we're going to kind of we're going to pause your charges. We're going to get you connected to behavioral health resources. And if you're doing well, those charges are going to go away. So it's a pretrial diversion. They've never gotten to the adversarial process yet. There's been a lot of people who have talked about upstreaming for competency because of this, right? Competency is really a major issue if we're trying to prosecute you. If we're not trying to prosecute you, it opens up some flexibility for how we might try to handle your case and get you connected to treatment with some monitoring. Intercept 3 is jails and courts. So here we're at the trial and sentencing phases. The goal here, again, is diversion, but it's either diversion from punishment, or if we can't divert you from punishment, it's a recognition that a behavioral health issue played a key role in your offending. So there's two foci here. You want to keep individuals in the community if possible. So you're thinking about, diversion and probation, and you're emphasizing rehabilitation as a principle of punishment because you're saying, we know that something happened and that you need to be punished, but we also know that rehabilitation is a key component here because you're probably going to do the same thing unless we meet this behavioral health need. Common strategies here include carceral behavioral health services or problem-solving courts or specialty dockets. Most people are probably on the call familiar with things like veterans courts, mental health court, drug court. So these are those types of interventions. I'm going to highlight a couple that I think are lesser researched or lesser known. Jail or prison therapeutic communities. So this could be after a disposition, right? You got sentenced. But I'm going to highlight an innovative program that Delaware has. They have, it's called the 6-for-1 program. It's a pretrial therapeutic community. There's not a lot of things in jails that focus on the pretrial population because you have no idea how long somebody's going to be there. So it's a very unique program that allows for that therapeutic community, that shared accountability setting, but at the pretrial level. So I just wanted to highlight that. I do a lot of work in Delaware, and I've been really, really impressed by that program. Medication assisted treatment is another good example. So in most jail, I don't want to say in most jails, in a lot of jails, they will, if you have a substance use problem, they might be able to connect you to MAT, something you might not have been able to get in the community. So you're thinking about getting people on things like methadone, buprenorphine, or naltrexone. Where I live in Philadelphia, we have a really robust program for MAT. I think New Mexico does as well. So you're seeing a lot of jails really taking that seriously and saying, if you have a substance use problem, even if you're here pre-trial, we want to help you get help for that. By the time you move to Intercept 4, now you're looking at post-conviction or post-punishment, right? Punishment has been imposed. And the goal is really, look, you're coming back into the community, and we need to help you achieve community stability. And the goal is focusing on helping individuals reintegrate. Notice I said reintegrate and not reentry. All reentry requires is a discharge date. I had an old mentor who told me that. But reintegration, he said, that's really difficult. So yeah, reentry is just I got released. Reintegration can be really challenging, and how do we help you do that in a stable way? Common strategies here, we're doing R&R based reentry planning generally, supportive step downs, and warm handoffs to services. So here's, I'm not going to go through this chart in detail, but Samhsa Gaines Center has a chart created by, I think, by Marlowe, that talks about what responsivity assessment and case planning looks like. How do you plan for somebody's stabilization needs? What criminogenic interventions do they need? What other things do they need to maintain stability after they achieve it? And do they have other needs that have to be met? For example, they have HIV and they need treatment. They have diabetes and they need treatment. They have a substance use problem. We want to make sure that they have overdose prevention strategies, etc. Other good examples in Albuquerque or Bernalillo County, they have the Resource Reentry Center. And what this means is that if you're released from Metropolitan Detention Center, they don't give you a bus ticket and say, good luck. They send you into the city of Albuquerque. You get released through the Resource Reentry Center, and it's a final chance for them to engage with you and help get you connected to the things that you need. Philadelphia also has the Office of Reentry Partnerships, which is really like an organizing structure for all of the agencies that do reentry in Philly. And so it's city run. And it also does things like get people connected to CDL classes, to cooking classes, helps them with financial literacy. You can get them parenting classes. So really anticipating the needs of somebody coming back into society and having some resources to help them meet those needs. At Intercept 5, we're thinking about community supervision. So again, we're thinking post-conviction here. The focus, just like Intercept 4, is achieving community stability. And what we really want if somebody's on probation or parole is behavioral health informed community supervision. So you're thinking about mental health training for community supervision officers, specialized caseloads. I think conditional release programs are a great example. So if you have an insanity acquittee, I used to work in Maryland. Maryland had a very good conditional release program. So once it was pretty clear that you could hack it outside of the hospital, they were going to release you. But they were going to do it with some conditions and with close monitoring. And if you were starting to decompensate and not do well, they could just move you back to a higher level of care. So it was really nice because it made it easier to discharge people. If you don't have conditional release, the bar is pretty high because you really want to make sure somebody's going to do well. Community partnerships are also key at this intercept. Things like FACT teams, so forensic act teams that can really understand the issues that justice involved individuals might face, or other community partnerships like I was looking at one in Texas where it was a juvenile probation department. They knew that it was hard for their juveniles to get access to medication. And so they worked with the university health system to get priority access to certain things. So some good examples there. When I was in Philadelphia working for the Department of Behavioral Health, we did some behavioral health literacy training for the entirety of the First Judicial District, including probation and parole. And so we were doing things like question, persuade, refer, or suicide gatekeeper training, the hearing voices simulation, sort of like empathy training, right? How do you recognize and understand that somebody's hearing voices, and what can you do that might be helpful? If you do notice this, what types of things might you do in the context of the justice system? Do you want to order a mental health evaluation? Are you concerned that somebody might have competency issues? Mental health first aid, right? So recognizing that individuals might have some type of mental health challenge, supporting them and encouraging them to connect to services. And then we also got a training grant for the Gain Center Trauma-Informed Training for criminal justice professionals. So understanding that nexus between trauma exposure and the criminal justice system, and how you take a more trauma-informed approach to supervision and just generally interacting with defendants. Another good example in Philly was the Resource Hub. So anybody from across the criminal justice spectrum, including probation and parole, could make a referral to the BHJD Resource Hub, who would assess needs and connect people to treatment. So if the probation or parole officer didn't feel comfortable but had a sense that something was going on mental health wise, they could refer it out to a specialist who could help. So you might ask, that's great. I now know what the SIM is. Those intercepts all sound really cool. Those interventions sound cool, but does it work? And the answer is a resounding yes, in a few different ways. So number one, SIM is a valuable tool for developing and maintaining community partnerships. All of those different interventions I just talked about probably highlight that. They're all interdisciplinary. It's the criminal justice system partnering with the behavioral health system. SIM is a valuable tool for identifying systemic strengths, weaknesses, and unmet needs. When they come in and do mapping exercises, they're doing gaps analyses. What do we have at this intercept? What don't we have at these other intercepts? How can these things work as a more cohesive unit? It's a valuable tool for making recommendations to improve the delivery of behavioral health services. So, good example, in Albuquerque, they have a tiny house village where you can go and it's transitional housing, but with wraparound services, all on campus. And originally they were having some difficulty getting those houses filled, but they talked to some people with lived experience and did not make it contingent on having sobriety. All of a sudden, those houses filled up and people are getting pretty good outcomes, right? Because now they can get on campus. As long as they're not using out in the open, they can stay there, and they're going to get connected to the services that they need to address their behavioral health issues. So that's a great example of an improvement in service delivery. Did we have a requirement that made this inaccessible before? It's also a valuable tool that can be modified to address the needs of specialized populations. So there's a veterans version of the SIM, an autism version of the SIM. They think about it as applied to juvenile justice. So it really is a great organizational and planning structure. It's also effective. So if the county invests in a pre-booking SIM strategy, so you're thinking intercept 0 and 1, what you'll see is that the number of individuals with behavioral health challenges that get admitted to jails, that decreases. When a county invests in a post-booking SIM strategy, so intercepts 2 through 5, connection to service rates for offenders with serious mental illness or behavioral health challenges increases. So those were two of the key stepping up metrics I talked about before that the SIM is directly impacting. What the research says is that the driving force is actually the SIM itself. It's not any particular intervention or strategy along the SIM. So it's not like, hey, SIM success is due to LEAD, or it's due to drug courts, or it's due to behavioral health literate probation departments. It's the layered nature of the interventions, and it suggests that really the collective interventions matter. Now, let's talk about what I think the SIM's active ingredients are. I've advocated before in my previous SIM talk for law and mental health that it's really a combination public health and public safety approach. And I previewed what I thought sort of the 6 different active ingredients are, 3 of them that are law related and 3 of them that are public health related. So let's talk first about therapeutic jurisprudence. Now, technically defined, TJ is the study of the use of law as a therapeutic agent or a change agent. How can we use the law to make positive change in people's lives? Practically, though, it's the idea that we can use discretion in the criminal justice system for the benefit of other people. And it's interdisciplinary in nature, meaning it inherently involves collaboration between legal professionals, medical professionals, and social scientists, just like you saw me talk about with all of those different interventions. Now, in large part, the SIM depends on the appropriate use of discretion in the criminal justice process. And I think I talked about this in my last LMH talk, but we utilize discretion in the CJS every day. Police can decide, are we going to arrest somebody or are we going to take them to a crisis stabilization unit? A prosecutor, there's no constitutional right to a plea bargain, but a prosecutor gets to offer you one. They might offer you an informal diversion and say, hey, if you connect to treatment, we'll dismiss these charges. Judges have a lot of discretion in sentencing. Do they sentence you in the higher end, on the lower end? Do they put you on probation? Do they order that you get connected to treatment? In the federal system, I've seen some evaluations that I've done where the judge will use that to recommend a specific facility that has a specific program. So judges have a lot of discretion in sentencing. Bail or pretrial release. So judges and prosecutors have a lot of say over whether or not individuals get released on bail. what conditions might be appropriate to help ensure they're going to show up to court and that the community stays safe. Diversion. Is the prosecutor going to offer you something like a drug court or a mental health court? Is there a judge who's interested in overseeing that type of a docket? And then community supervision. Is your PO going to violate you for not showing up to this appointment? Are they going to be more understanding that you didn't have childcare that day? So we exercise discretion in the criminal justice system every day, which is the basis, again, of therapeutic jurisprudence. You'll notice before I didn't mention anything about defense attorneys, but they have a ton of discretion too. They have discretion to advocate. So they can advocate for their defendants who might have a behavioral health challenge and say, look, they can be on pretrial release. They just need these extra stabilization resources. They can advocate for participating in problem solving course. Hey, my defendant is a great candidate for success in drug court. They can advocate for reentry support. So I've seen plenty of public defenders' offices that have robust relationships with community providers and know where to send people when they have certain issues. And then they can advocate for defendants with behavioral health challenges not to be violated on probation. So, hey, can we scale up the intensity of probation? Can we get them connected to this service instead of violating them and putting them in jail? Second, so that's the first active ingredient, the practical use of therapeutic jurisprudence. The second one is public health related, and this is a prevention approach or a systems-based approach. So some of you might be familiar with the Swiss cheese model of disease prevention. I've talked before. I learned about this when I went to Metropolitan Detention Center in Albuquerque. It was in relation to COVID, and it was essentially like we've got these 4 pieces of Swiss cheese stacked up. So, the germs aren't going to be able to get through all of these pieces of cheese. So like if you wear a mask, if you stay 6 feet away from people, if you make sure to wash your hands and wash surfaces, it's less likely that you're going to develop COVID, right? So it's kind of this, if we layer enough things, it really makes it difficult for these germs to get across. It makes it difficult for this negative outcome to happen. The SIM is designed exactly with that in mind. So I know that it's called Sequential Intercept model, but when Patty Griffin gave her, I guess you call it the life, whatever the APLS version of the Lifetime Achievement Award is, or the Contribution Award, she talked about how it was originally going to be called Sequential Filter Model. And in the original SIM article, they portrayed it as a series of filters. More people are supposed to get caught at earlier intercepts, and the more of those layered things that we have, the fewer people should be getting all the way down to intercept 5. So SIM was inherently designed to focus upstream and have a series of filters so that we can catch people downstream, but hopefully not too far downstream. Now, we can think about the prevention continuum or the continuum of prevention, whatever you want to call it, when we think about the SIM. There's different types of prevention. So there's primordial prevention, you're targeting risk for risk factors. Primary, you're targeting risk factors. Secondary, meaning intervene early. So some low-level negative outcome has occurred. We need to intervene before it escalates. Tertiary, this really negative thing has happened, and we need to prevent it from happening again. And then quaternary is preventing over-criminalization, or in public health speak, over-medicalization. So the SIM is this whole idea, let's prevent people from moving further through the justice system. The whole thing is designed to achieve quaternary prevention. There's also quinary prevention, and this is let's not spread misinformation, right? And you can think about all the different types of misinformation we have in the criminal justice system as it relates to mental health. Now, in the talk I did last year, I talked about mapping different types of prevention onto the SIM. So you can see that intercepts 0 and 1 are really focused on primordial prevention because you want to prevent formal entry into the criminal justice system, right? You're targeting those risk for risk factors at intercept 0, and you're targeting the risk factors at intercept 1, right? How do we address the risk factors for you becoming involved in the criminal justice system in a way that we truly care about? Intercepts 2 and 3 are secondary prevention. So here some less severe offending might have occurred, and we want to prevent it from escalating. So we're going to do that via diversion. Look, we know that instability and substance use is contributing to your offending. Let's not toss you in jail, but let's divert you to the behavioral health system, but we have a watchful eye on you. Tertiary or carceral treatment. Look, we understand that some level of punishment is needed here, but if we don't give you the appropriate treatment, when you get released, we're going to see you back again. So again, you're trying to prevent the escalation to more severe offending. Intercept 4 and 5 are really focused on tertiary prevention, right? You don't re-enter unless you've been jailed or imprisoned. at Intercept 5, you're not on probation or parole unless you've either come back from the facility or you've been convicted of something. So here, a negative outcome has occurred, and we're really trying to prevent its recurrence, right? So you can see that Intercept 0 and 1 nicely on primary and primordial, 2 and 3 fits nicely on secondary, 4 and 5 fits nicely on tertiary. Like I said, the entire criminal justice spectrum aspect of the SIM, 1 through 5, is quaternary prevention, and the entirety of the SIM is quinary prevention, right? How can we better address the needs of individuals with behavioral health challenges to avoid them perpetually cycling through the justice system, particularly because we know that behavioral health challenges are not generally a risk factor for criminal justice involvement. Moving on to procedural justice, the third active ingredient. This focuses on how individuals view the legitimacy of the criminal justice system, whether they accept decisions that are made in the criminal justice system, and whether they're willing to obey society's laws. Now, procedural justice argues that sanctions are more likely to prevent crime when people buy into them, essentially, when they're perceived as fair. This contrasts starkly with deterrence theory. So there's a reason it's called procedural justice. Do people trust the process? Now, key factor. So let's first talk about key factors of deterrence theory. Deterrence theory essentially says people are going to be deterred from criminal behavior if we punish them, and that punishment is certain to happen, it happens quickly, and it's severe. Contrast that with procedural justice. That's focused on neutrality. So are these decisions unbiased, and are they transparent? Do we understand how they were made, and they look fair? Are people treated with respect in the context of the criminal justice system? By law enforcement, by attorneys, and by the courts? Do they trust the decisions that these individuals made? Do they feel like they're well reasoned, that they're based on facts, that they're based on an understanding of the person's situation? And can that person even talk about their situation? Are they given any voice? Are they given a chance to tell their story and how they might come to have been involved in the justice system? So you can see that there's a key difference between how we think about deterrence and how we think about procedural justice. The other thing with procedural justice is it comports with public opinion. Most Americans believe that individuals who are justice involved and they have behavioral health challenges, that they should receive some type of treatment, not incarceration. Most Americans also believe that incarcerated persons should get better health care, including behavioral health care. And about half of Americans think that the police force is insufficiently trained to deal with individuals with behavioral health challenges. So another thing that you're thinking about with fairness is that it comports with public opinion, or it encompasses the public voice, and procedural justice, or the SIM, certainly does encompass how most Americans now think about the relationship between behavioral health challenges and the justice system. So one thing procedural justice does, and the SIM does, it acknowledges that for some people, criminal offending is best viewed as stemming from unmet behavioral health and stability needs rather than criminal propensity. So go back to that one of those first slides I talked about. Most people are saying the point of the criminal justice system is to punish criminals, not to punish people with unmet behavioral health needs. Procedural justice and SIM emphasizes rehabilitation as a key principle of punishment. It's saying, look, instead of focusing on those top three that we talked about, deterrence, retribution, and incapacitation, we really want to emphasize that fourth one, rehabilitation. And inherently, procedural justice focuses on therapeutic jurisprudence, and that helps facilitate trustworthiness and respect. Now, moving on to another public health aspect of the SIM, R&R. So when we think about R&R, the easiest way to think about it is the risk principle says, who should we treat? If you have more risk factors, you need more intense treatment. The need principle says, what should we focus on? So not every offender has the same dynamic criminogenic needs. This person might be really susceptible to social influence and substance abuse, versus this person really might be offending because of lack of economic means, right? Education and employment is the key domain for them. So how do we give you the things that you need for the things that you need, right? Instead of taking a one-size-fits-all approach. Responsivity talks about how we should be working with somebody. So we're thinking generally, right? Can we give you an evidence-based intervention, something we know works? But then specific, what's your individual situation? How do we adapt treatment to meet your needs? And I talked before, I previewed systemic responsivity. How do we make sure those resources are actually available? So sequential intercept model encompasses the risk principle because again, it's like that series of filters. We escalate interventions, we escalate supervision as you move down the criminal justice spectrum, as you move down intercepts. The need and responsivity principles are focused on because the sim is designed to help people meet their criminogenic needs. What are the things that we know will reduce recidivism? But also, how do we stabilize you? Right? How do we recognize that mental illness, trauma, cognitive deficits, lack of motivation might be leading to instability? We need to address those things before we can address your criminogenic needs. So here it's really focusing on SDOHs and SDOMHs. So you're focusing on criminogenic needs, but also responsivity needs. I won't go over this in a ton of depth. I think I've talked about this in the previous LMH presentation. But when you think about responsivity, you're thinking about what are the stabilization needs somebody has? How can they get community stability? And what are their maintenance needs? What are the things they need to stay on the straight and narrow, to stay stable in the community? So if we get them to stability, how do we maintain stability for them? And you'll see that mental illness and STOH deficits and STOMH deficits really do map onto this idea of responsivity needs. The last legal thing we'll talk about is restorative justice. So restorative justice prioritizes the harm that results from criminal offending to victims, societies, to the offender themselves, instead of focusing purely on retribution and just deserts. Harms yield obligations under a restorative justice framework. So a wrongdoer has to take some accountability to repair the harm they caused, but also to address the causes of their offending. So how do they rehabilitate or reform themselves? It focuses heavily on engagement. There's always multiple stakeholders and multiple voices at the table trying to figure out the best community approach to remedying the harms and the causes of harms here. It really focuses on repairing harm, so kind of a harm reduction framework that's caused by criminal offending. Now, some of the key interventions in a restorative justice framework. You have family group conferences, so you're really focused on incorporating family members. Circle sentencing, which means it's not just the judge, you're getting input from a whole bunch of different stakeholders. Restorative justice focuses on victim empowerment and offender accountability, right? The victim gets to have a voice in repairing their harm, and the offender gets to take accountability for their actions and try to make amends. And then the community is really involved in a restorative justice framework. And I think based on some of the interventions we talked about, you'll see how restorative justice gets reflected in there as well. Because there's input from multiple stakeholders, and ideally, these are things that are situated in the community. It's focused on rehabilitation, so you're addressing the causes of offending, and that's exactly what the SIM does. And you're focused on community reintegration and stability. And the whole purpose of the SIM is to help people maintain community stability, and wherever you are along the criminal justice spectrum, getting you connected to those stabilizing resources. The last public health thing I want to talk about is addressing STOHs and STOMHs. So I think last time I talked about that STOH and STOMH deficits place people at higher risk for justice involvement. And this is, again, the whole idea that instability can yield justice involvement. They are some of the strongest predictors of first contact with the justice system, but not necessarily recidivism. There is a reciprocal relationship between these types of deficits and criminal justice involvement because of collateral consequences. And there's also this there's this intuitive relationship where these deficits put people at risk for behavioral health challenges, which might put people at risk for criminal justice involvement, which might put people at risk for behavioral health challenges and more STOMH deficits. So it's a circular relationship here. Now, when you think about STOMH deficits, they're really responsivity needs. What are the things you need to stay stable in the community? And you can see they map pretty closely onto Maslow's hierarchy of needs. We need to address these lower rungs in order to help people self-actualize, to feel good about themselves, to stay completely out of the justice system. I'm not going to go through this in a lot of detail, but if you think about SDOHs, the biggest thing for the SIM is SDOMHs. And so it's mostly SDOHs, but also thinking about things like access to care, discrimination, ACEs, those types of things. So you're really, again, they really kind of reinforce each other, but there are some extra considerations you have if somebody has a behavioral health challenge. You're again focused on responsivity assessment and case planning. That responsivity needs are STOH and STOMH needs. And the SIM already encompasses a lot of support for STOHs along the different intercepts. So they often refer people to wraparound and case management services. We have carceral programs to help people do things like get GEDs, take college courses, get vocational training. We provide reentry support that's R&R informed. And a lot of times community supervision officers connect people to STOH resources. So a few takeaways here. Individuals with behavioral health challenges are overrepresented in the criminal justice system. The SIM is the predominant model for decriminalizing behavioral health challenges, for reducing that overrepresentation. Research suggests the SIM is an effective tool for doing that, at least in terms of reducing admissions into jail and connecting people to treatment. And it really does represent a blended public health and public safety approach. I'm going to advocate again that the SIM has 6 active ingredients, 3 of which map onto public safety, therapeutic jurisprudence, procedural justice, and restorative justice, and 3 of which map onto public health, the continuum of prevention, R&R, and addressing STOHs or STOMHs. And I hope that the overall takeaway for the audience is that you can talk about the SIM in many different ways to reach different types of audiences. And you can say, hey, do you know about therapeutic jurisprudence? That's what the SIM is. Oh, do you know about addressing STOHs and helping get people stable? That's what the SIM is. So hopefully it gave you some different dialects to talk, different dialects of the same language, so that you can speak to different audiences intelligently about the SIM and maybe advocate for it in your jurisdiction. Overall takeaway is we don't have to choose. We can have both a public health and public safety approach. And with that, we've got a couple minutes to take any questions before we hit the top of the hour.
Yes, thank you so much, Dr. Fairfax-Columbo, Jaymes, of course, for this helpful overview and diving a little bit more into the meat of SIM. And this is much appreciated perspective. And like we do have a couple of questions in the Q&A box. You can feel free to enter any of those if you feel comfortable. Just know that we will wrap up in a few minutes here, but we'll address any questions we can. In the meantime, the chat box does include the CEU survey link. You can go ahead and copy that, open it, bookmark it before the webinar closes for those of you that are pursuing APA continuing education credits. Somebody is asking from more of a historical lens about SIM, given your background in this area. They wanted to know more about how this came together. Was this a grassroots idea with a strong person team behind it? Did it move more top down, like a mandate from state government, or a grant was written? How did this come to light?
Sure. So I think if you ask Dr. Griffin, the co-creator of the SIM, this really did start as it started with an academic interest, hey, but it was coming from grassroots things. What's an organizing structure that we can use to think about how we address this nexus? And it really started kind of in, I think it was Ohio and the Philadelphia area. So I often appreciate that I live in Philadelphia because they've been exposed to the SIM for quite a period of time. So it lets you maybe think more deeply about the SIM because you just have had more time to engage with it. And I think what you're seeing now, because the SIM is starting to catch on, now it is coming from top down. So like I know New Mexico has a vested interest right now at the state level in saying, how can we support the counties with the SIM? And there's plenty of other states that are like that. So it's kind of a mix of both. It started grassroots because it was so successful. Now you're starting to see a little bit of mandation is probably not a word, but it getting mandated. Um,
Wonderful. Yeah, thank you for that context there.
mhm.
And a related question from this same person. They wanted to know about the potential applicability of this to the forensic psychiatric system, as opposed to, say, a more correctional system. Any insights about this particular branch?
Sure. So actually, this was part of the talk that I gave, the symposium that Chris King, Dave DiMatteo, and I did at APLS, where we talked about conceptualizing the relationship between behavioral health challenges and crime. And the SIM actually probably should look a little bit different if behavioral health challenges completely explain why you're involved in the justice system. So if you were to go and map that on, um, basically what would be different? Intercepts 0 through 3 that are focused on not prosecuting people shouldn't look much different. But from 3 onwards does look different because you're absolved of responsibility, but now we're putting you into some type of forensic hospital. But you have all the same, forensic hospital, still a carceral facility, right? It's focused on incapacitation and rehabilitation as opposed to deterrence and retribution. So you still need to do reentry. And if you have a conditional release program, that's really mental health probation or mental health parole. So it has a lot of implications for that. It just changes a little bit the conceptualization that you might have in terms of whether um, the more formal criminal justice system should be involved, or it's kind of like the pseudo criminal justice system that is blended with the behavioral health system, like the forensic hospitals.
How do you respond to arguments about scalability or feasibility when it comes to directly applying application of the SIM?
that's next year's talk about systemic responsivity. And what I will say is that's a great point. And I always say you need infrastructure to build infrastructure. So if you don't have the SIM is inherently based on can we make use of community resources, unless it's you're doing carceral treatment. But even then, like maybe your penal facility just doesn't have those types of things. So I do think when you're planning through the SIM, the real question to ask yourself is, do we have a robust behavioral health system in the community where we can actually do a partnership between the criminal justice system and the behavioral health system? So that would be things like, do we have enough stable housing? Do we have enough shelters? Do we have enough providers? Do we have some crisis interventions? Like all those things need to be present. So in order to scale it up, it's not hard to scale it up if the resources are there. In terms of scaling it up, I think a lot of places do grants. So like a lot of drug courts come from grants. Now, and I think there's always a problem with grants because they focus on different things and they can dry up. One thing I think people have had success with is philanthropy. So you can think about individuals who have significant resources but who want to give back to the community. They might sponsor like a foundation grant or the Arnold Foundation, things like that. So you can scale it up as long as you have those resources in place. I think you might need to get a little bit creative regarding money in terms of grant funding or foundation funding. The ultimate way to get money flowing into a jurisdiction is to have a lawsuit. So that's not the preferred way to go through things. But I think when a lot of jurisdictions look more flushed with cash to address these issues, it's because they had a really bad issue that they got sued for. So I'm not averse to lawsuits because I think in the US, that's how you advance some of these issues. But obviously, it's never fun to get sued and to say that for somebody to say your system is lacking.
For the sake of time, I'm going to summarize one of these questions that somebody has. They provided a context that says, in California, forensic hospitals, we've been instructed to diagnose people who describe histories of amphetamine psychosis with schizophrenia if it's lasted long enough. Their question gets at this issue here of substance use and potential misdiagnosis of psychotic symptoms, saying if we would properly identify substance use, it would dramatically reduce number of patients who the SIM applies. Do you like the goalposts where they are now, i.e., a lot of amphetamine psychosis being called schizophrenia, or would it be better to move the goalposts?
So, one thing that I will say at the beginning of the presentation, I talked about behavioral health challenges encompassing more than just your standard psychiatric disorder. So it does also encompass substance abuse disorders. Because if you're thinking about the conceptualization of how did this behavioral health challenge relate to what happened to this individual, the SIM really applies pretty broadly, even for personality disorders, right? If there's enough of a contributing factor, some type of treatment or rehabilitation is going to be helpful. I think with things like amphetamine-induced psychosis, this is something that I dealt a lot with in New Mexico, that I still deal a lot with in some of the other evaluations that I do. When I was in New Mexico, I had I would essentially say sometimes this person has methed themselves into real psychosis, right? Because if it lasts, like there's enough brain changes that now they have a true standalone psychotic disorder. So if that's the case, where somebody now has this thing that would exist independently of substance use, that really neatly does fall into the SIM. That's just sort of standard SMI. It is not that, right? Where it's only substance-induced psychosis. You can still be thinking about the SIM, but maybe it changes the intercepts that you're going to be at. So the question that I answered earlier about the forensic system, there's a reason that a lot of jurisdictions don't allow for an insanity defense if the mental illness was caused by substance use and doesn't exist independently, right? And then you're looking more at sort of the substance use and mental illness as a mitigating factor. So maybe that helps answer the question. It's really about the conceptualization to figure out where along the SIM you should intervene. And the SIM doesn't necessarily mean we should never punish people, right? Intercepts 3, 4, and 5 are focused on punishing people. But it's saying that along this whole thing, rehabilitation needs to be one of the primary principles of punishment, not the quaternary principle of punishment.
Dr. Fairfax-Columbo, Jaymes, again, thank you for all the work and the outreach you do regarding the sequential intercept model, again, and sharing all of your expertise and knowledge of this for us today. And of course, it is always great to have you back here in your UNM home. So good to see you again, and
See you
we'll
next year for
have you
systemic
on.
responsivity.
Exactly. I already made a note of it. Yeah, I typed it out. That does wrap up this week's Law and Mental Health series. We hope to see you next week when Dr. Heath Hodges will be going over AI, ethics, and the law. We hope to see you then for another great discussion of behavioral health issues in the law. Until next time, take care.